I don't understand the meaning of some words in quiz or exam. So since I cannot figure out the meaning of the question, there is no way to find the answer.
Yep.
I study so hard, but I don't understand the meaning of the questions.
So what do you mean by, are you not understanding the gist of the question, or there is
One word I stuck there, or the meaning of the question that it asked. It Miss
Like, give me an
Richards.
example.
Miss Richards went over my quiz. I mentioned the topic, but the question asked me specific things that I didn't figure it out. That's my problem, and I have no idea what I should do. Exam today, that was lots of words that I didn't know the meaning of them.
Okay.
Not about the studying.
Yeah.
The rest of the courses is okay, it's doable.
Yeah.
But this one, I can't understand.
Why do you see this? Why do you think there is a difference between the other courses and this with regards to learning?
Those are easier.
Understand. So, but
Not so much meaning. Like we have farm. I don't need to know every words. I just memorize the name of the meds. Or on pre-clean or what else we have? We have medcom. So we study the questions that we ask from the patients or diseases. So I understand them.
yeah, but I'm trying to understand is, how
I have this problem on a quizzes
So
too.
what we should do is maybe actually sit down, like once she grades the exam, to actually sit down and then look at each of those questions individually, and then see where exactly is the area that you feel like you're not able to comprehend, and then see if you can come up with
Because today the choices was different words. Means the atrophy or hyperplasia. I know the hyperplasia, its number of the cell goes up, but it didn't say the number goes up. It's different.
Okay, so that's what I'm saying. So what we should do is look at the questions, and then say, because when you read a topic, right, you shouldn't. What happens is if you just memorize the way the topic, like for example, just take hyperplasia. If you memorize it as this increase in the number of cells,
Yes.
then if the question is presented to you in a different way, like for example, it's asking the same thing, but if
It's different words.
if it's not using how you guys have memorized it from your handout, then that.
I study, I understand what is that.
Yeah,
but
but
when
the
it
thing is-
asks, I stuck there.
No, but the thing is, you have to. It's important to understand the concept, not actually memorize.
I understand the
word.
concept.
Yeah.
Yes.
So when you understand the concept, no matter how the words are used, it should still get you to the answer. So that's why if we sit down and look at the questions and see how you're viewing
On a
them.
multiple choice, I can guess
Yeah.
because it gives me an option. But in the quizzes, there is no way.
Yeah, no, and that's why it's important for us to kind of sit down and see, if we can sit down and then gauge or analyze and see.
Okay.
Is it the.
Should I take an appointment with you?
Yeah, so
Okay. Email you?
Just send me an email.
Email
with
you.
the-
I'll
with
do
the
it.
dates and
I'll do it.
times,
Okay.
Either this week or.
Your email address is on a syllabus too?
Yeah, it should be on the syllabus.
Okay.
It's Age Gandhi at LLU.
Thank you so much.
Yeah,
Really
and we'll sit
appreciate
down
it.
and then figure
Thank
out.
you.
No worries.
Oh yeah? David Girls? Oh really? Yeah. Okay, so when you put in your tea, it focus straight up.
I know that like
Oh, you do? I have. They're like kind of like. They don't have any.
Did someone leave their phone up here?
What's up?
They said someone left their phone up here.
Oh, someone left their phone?
Did anyone leave your phone up here? Phone. Does this phone belong to someone? Okay.
That's not me.
I said put him on ice. Watch, if only you want to get that question right.
Bless
you. Bless you. One person on your left answer right.
Okay, can you guys hear me?
Yes.
Perfect. So, can I have everyone's attention? We can discuss the examination after your class is done, not right now. Okay, so we're going to continue with our topic, soft tissue lesions, and finish up the rest of the entities, as many as we can. So we're going to move on to the next entity in soft tissue tumors, which is neurofibroma. Remember when we talked about neural lesions, we talked about reactive lesion and then true tumors. So reactive lesion, an example was traumatic neuroma, and then the true tumor would be a schwanoma or a neurofibroma. So it just depends on what part of the nerve cell the tumor arises from. You can either end up getting a schwanoma, or you can the patient can end up getting a neurofibroma, right? So if it arises from the Schwann cells, then it's called schwanoma, and if it arises from the perineural fibroblasts, it would be a neurofibroma. Okay. And so typically, whenever you look at a schwannoma or a neurofibroma, just by looking at it, it's hard to make a diagnosis, right? So this usually falls under differential diagnosis. This tends to have a predilection for the tongue. That's the more common site. You can also see it on the buccal mucosa. So if you guys see something like this, how would you describe it? Oops. What part of the mouth is that? Lateral tongue, right? Okay. Is that a single lesion or is it multiple lesions? Single lesion. Okay. Is it well defined? Yep. Does it look like it has the same color as the adjacent mucosa, or is it different? Different, right? What is the color on the top? Looks white. So it looks like there's a hyperkeratotic surface on top of the lesion. So that's basically because it's on the lateral tongue, so patients have a tendency to basically chew on their tongue, and then when they have a lump like that, and then that in turn induces, keratosis to form, and then causes this whitish appearance. Okay, but not every neurofibroma is going to have a white color to it, right? So they usually are the same color as the adjacent mucosa, but if there's friction, then you're going to see whitish hue to it, or they can have a yellowish color to them. What was another lesion that we talked about that has a yellowish hue? Ulcers, it's because of membrane, right? Lipoma was another one that we said is inherently has a yellowish hue to it because of the adipocytes or the fat cells. So neurofibromas can also have a yellowish hue to them. What is the most common location for a lipoma? What are the two most common sites in the oral cavity? The buccal mucosa and the vestibule. Buccal mucosa and vestibule are the two most common sites. For a neurofibroma, it's actually tongue and buccal mucosa. Okay. So, like other soft tissue tumors, a neurofibroma also has to be removed entirely. So, surgical excision is the treatment of choice. The one risk with this neurofibroma is if there's just one of these tumors present in the mouth, then it's okay, right? But if they have multiple neurofibromas, then we need to be concerned about a condition called neurofibromatosis. Okay? So this is basically a genetic mutation that happens on a certain chromosome, and then that in turn leads to a patient developing multiple neurofibromas. But the problem with when someone has multiple neurofibromas is those neurofibromas can actually turn into cancer. Okay? So they can become neurofibrosarcomas. Okay, so they can turn into malignancies. Okay, so there's another entity that is also nerve origin, and that's called granular cell tumor. This one has a high predilection for the dorsal tongue. So if you see a really well-defined lump on the dorsum of the tongue, you have to consider granular cell tumor in your differential diagnosis. Okay, this is not very common. It's benign. This arises from Schwann cells, and this is what it looks like. So it's usually on the dorsal tongue. Okay. When we looked at neurofibroma, when we looked at traumatic fibroma, they all tend to be more common on the lateral tongue, right? But then granular cell tumor tends to be more common on the dorsum of the tongue. And it looks like a very well delineated solitary nodule, okay, on the dorsal tongue. It has a smooth surface, and it's the same color as the adjacent mucosa. And this tends to be a little bit more common in women compared to men. Okay, and then granular cell tumors can also have a yellowish color to them. Okay, this one is more on the lateral tongue. Okay, so if you see something like this, that would be hard to differentiate between a neurofibroma or a granular cell tumor. Lipoma, this is not the most common site, but you can think of that. And there's another entity we'll talk later on called oral lymphoepithelial cyst that also has a yellowish color to it, and it's also on the lateral tongue. But it's more posterior on the lateral tongue. So towards the foliate papillae is where you see oral lymphoepithelial cyst. But all of those can appear as yellow masses on the tongue. Okay. So again, you're seeing what looks like a pretty discrete nodule on the lateral tongue. It is very well defined. It has a nice smooth surface to it. So there's no ulceration or anything. The big problem with granular cell tumor is when they do a biopsy. So what happens is when a biopsy is done, if you look at the epithelium right here, so that's intact epithelial surface. But if you start coming to the bottom of the epithelium, you see some of these epithelial islands, they're separating from the top layer, right? So you notice that some are separating from the top layer. They're not continuous anymore. And then if you see right here where my arrow is pointing to, you see there's some keratin in there. Okay? So if you see these features, one of the things, if someone is not familiar, with looking at these things, they might misdiagnose this as a malignancy, as cancer, as squamous cell carcinoma. Why? Because it shows all of those features of squamous cell carcinoma in the epithelium. It's proliferating into the connective tissue, it's separating, it has keratin pearls, but then the difference is you have to look in the connective tissue. If you look in the connective tissue, how does the cytoplasm look like to you guys? Does it look uniform or does it look granular? Does it look like it's a little clumpy? Right? So this is what the feature that you see. Typically, if you look at cytoplasm, it's one smooth kind of surface, right? But here it looks more granular or clumpy. So that's why it gets the term granular cell tumor, because of these granularity to the cytoplasm. So in a squamous cell carcinoma, you're not going to see this granularity. That's the big difference. So what you guys need to remember is histologically, that's when a biopsy is done, this is commonly mistaken for a squamous cell carcinoma. Okay, you don't need to know the histology, but just know the reason why it gets commonly mistaken for a squamous cell carcinoma. And then the way you treat it is with surgical excision, and they rarely come back. Okay, so all the nerve tumors, so basically you have reactive lesions and you have true tumors, right? So what was a good example of a reactive lesion that was nerve in origin? Whenever I say reactive, there has to be a source of trauma, friction, or irritation, right? So a traumatic neuroma is an example of a reactive nerve lesion, okay? And if you're talking about a true tumor, then you have schwanoma, you have neurofibroma, and then you have granular cell tumor. All three are nerve tissue origin, okay? So depending on the subtype of cell, you get different tumors. So if it arises from Schwann cells, it can be either a schwanoma or a granular cell tumor. If it arises from both Schwann cells and perineural fibroblasts, it's a neurofibroma. Okay, so but those three are true nerve tumors. So in soft tissue tumors, please make a list of ones that are reactive in origin and that are true tumors. You need to know the difference between something that happens just as a reactive lesion and something that's a true neoplasm. Okay, so we'll move on to the vascular lesions. Okay, so the broad category of vascular lesions are usually called hemangiomas and vascular malformations. So what is the big difference between a hemangioma and a vascular malformation? The difference is in the pathogenesis. How does it arise? Okay, so if you look at a blood vessel, what are the cells that line the blood vessel? What do you call them? Endothelial cells, right? So if the endothelial cells, they proliferate, okay? But it's just all the endothelial cells that are lining the blood vessels, they start increasing in number, okay, and they're abnormal. That's when you get a hemangioma, okay? In a vascular malformation, your endothelial cell number is the same. That's not going to change, but you'll have a lot more blood vessels, okay? So that's the big difference. So in hemangiomas, the reason why you see a hemangioma is there's more endothelial cells that proliferate and multiply, and then they eventually form a tumor. A vascular malformation, on the other hand, is you have normal number of endothelial cells lining every blood vessel, but there's just lots of blood vessels, way too many blood vessels than normal. Okay. So there's a really huge classification for vascular lesions and hemangiomas. You don't need to know the entire classification. I just took out the ones that I thought was critical for you guys. So if you look at vascular tumors or vascular lesions, you have two broad categories. You have vascular tumors, out of which hemangioma is the more common one. And then you have vascular malformations, and there's different types of malformations depending on what type of vessel was involved. Was it a capillary that was involved? Was it a vein that was involved? Was it an artery that was involved? Or is it a combination? Okay, so if you have increase in number of lots of capillaries, then you call it a capillary vascular malformation. If there's an increase in the number of lots of veins, then you call it a venous malformation. If there's increase in the number of both arteries and veins, okay, the blood vessel itself, then you call it arteriovenous vascular malformation. So how do they present clinically? So when we talk about hemangiomas, they typically are seen when as an infant, when the child is an infant, right? So during the first 8 weeks of life, you typically don't see it at birth, but within first 8 weeks of that infancy, these lesions arise, hemangiomas. Okay, but the thing with hemangiomas is they grow as the child grows. Okay, and then also there is an initial stage where they are exuberantly growing, and then if you look at the surface of these hemangiomas, it almost looks like a strawberry. Okay, so that's why they call them strawberry hemangiomas, because the surface of it mimics a strawberry. Okay, so what happens is you get this exuberant growth, and then they start reducing in size. Okay, so typically by the time a kid turns either age 5 or age 9, maximum by age 9, 90% of these hemangiomas will go away on their own. So you don't need to do anything about it. Okay, so hemangioma, whenever we talk about a hemangioma, the things you have to remember is this is something that arises in infancy. You may or may not see it at birth, but at least you'll see it within the first 8 weeks of life, okay, of that child. And then it has an exuberant phase where the surface of that mimics a strawberry, okay? And then as the child starts growing, it will get bigger, but then it starts regressing, okay? So by the time a kid turns 5 or 9 years of age, 90% of these will go away on their own, and you don't have to do anything about it. Okay. Whereas if you look at a vascular malformation, on the other hand, right, vascular malformation is usually again seen in childhood, or sometimes patients are not even aware that they have these, and then it can be seen as an adult. Okay, and then when it's seen when a patient is if this lesion is seen in a patient's childhood, it actually increases as the child grows. Okay, and once they finish their growth and development, it kind of stabilizes in size and it doesn't get any bigger, and it looks exactly the same. So if you talk to a patient and in the history they tell you, I've had this all my life and this is the size of it, it hasn't changed in size, this is what it looks like, then you're dealing with more likely a vascular malformation. But if they tell you that I've had this when I was an infant, okay, it got really big initially, but then it kind of started getting smaller, and then now it's about this size and this is what it looks like, then you're thinking more along the lines of a hemangioma. Does that make sense? So a hemangioma, the history would be, I had the lesion as an infant, it grew really fast, really big, and then it started getting smaller, okay, and now this is the size I have. If it doesn't go away on its own, right, then you're thinking this is a hemangioma. In a vascular malformation, the history would be, I've had this as a child, but it grew as I got bigger, the size of the lesion also got bigger, but once I became an adult, then this stopped growing, and it has been that size since then, okay. But both of them, the history is that they'll have it pretty much all their life. This is not something that, except for vascular malformations, occasionally you can see them as an adult, and you don't see them in childhood. Okay, so, and if you're dealing with an arteriovenous vascular malformation, especially, if you take, for example, if you consider this as an AV malformation, if you take your finger and you put your finger on top of this lesion, it's going to feel really warm to touch, okay? And then you're also going to feel a pulsation in there. So AV malformations are actually pulsatile lesions. So you'll feel a pulse and it's going to be warm to touch. So those are two big clues that you're dealing with an arteriovenous vascular malformation. So anytime a lesion is warm to touch and it's pulsatile and it looks vascular, you're dealing with the subtype of arteriovenous vascular malformation. So they usually, what kind of color would they have? What is the color that you're seeing here? Kind of bluish purple, right? So that's because these are vascular lesions. So typically either a hemangioma or a vascular malformation, both are going to have this bluish purple color to them. And then we do what's called a diascopy test. Do you guys remember a diascopy test from physical and chemical injuries when we talked about hematoma? Okay, so what happens? A diascopy test is basically either you take your fingers or you take a glass slide and you apply lateral pressure on this lesion, right? So if I took my fingers and I push the side of this lesion, okay, the area where I actually apply pressure, the color is going to change, okay? So it's going to look paler in color. It's not going to look bluish purple anymore. The reason why you see that is actually because the blood actually gets emptied out of the blood vessel. And then once I remove the pressure, the blood fills back up again, and then it's going to look bluish purple. So if there is a lump and you apply lateral pressure like this, the area that you apply the pressure, if that area changes color, it becomes more pale. And then once you remove the pressure, if the area fills back up with blood and then starts looking more bluish purple, then it means that it's a positive diascopy test. That means it's blanches with pressure. Okay, so that indicates that this is a vascular lesion. It's made up of these blood vessels, and then because you applied pressure, blood got emptied out of the blood vessel. Once you remove the pressure, blood filled back up in it again, right? But why doesn't a hematoma blanch with pressure then? Remember when we talked about physical and chemical injuries, I said if it's a hematoma, it can look exactly like this, right? It's a mass, it looks bluish purple. How will you differentiate between this and a hematoma if this is your patient? Blanching, okay? Does hematoma blanch with pressure? No. Why not?
Outside the vessel.
That's right. Because the vessel is already ruptured. The blood cells actually came out of the blood vessel, and then they accumulated underneath the mucosa. That's why you ended up getting a hematoma. So if you're applying pressure there, you're not emptying anything out of a blood vessel, right? Because it's already ruptured and the cells are already out. So it's not going to do anything. That's why a hematoma doesn't blanch. Whereas a hemangioma or a vascular malformation is going to blanch because the blood is still in the blood vessel. Okay? So that's the big difference between hematoma and vascular malformation or a hemangioma. One blanches and two of them blanch and the other one doesn't. Hematoma does not blanch. Okay, because something like this, if you got it on a quiz or an examination, that could be your differential diagnosis, right? Those three entities. Then you need to know how to differentiate between them. Okay, so that's critical. Or you can get a mass like this. Okay, again, history is also important, right? You have to find out, does this patient have a recent history of trauma? Okay, was there surgery done? Was a tooth taken out? Did they have some kind of injury, right? If they see this and this is an acute process, then it leans you more towards a hematoma, right? So if the patient tells you, I've had an injury and I noticed this lump right away, then you're thinking that this is an acute process, more likely hematoma. But if the patient tells you that I've had this all my life, and it's basically either the same size or it's got bigger and then reduced in size, then you're thinking either hemangioma or vascular malformation. So history and diascopy test are two useful tools that you can use to differentiate between these entities. Okay, so the common theme from all the clinical pictures that you're seeing is the color, right? All of them look that bluish purple, may have a little bit of a reddish color to them too, but they all have this, when you see something that's vascular, that's the color that you expect, okay? And then they're all pretty well defined. They're localized, okay? They're single lesions, typically, if you look at them. And the surface of it either can be smooth or it can be lobulated. And then you have to make sure you do a diascopy test to establish what it is. And also touch the top of the lesion to make sure that it's not warm to touch or it's not pulsatile, okay? Because if it's either of those two, what diagnosis would you make? If it's pulsatile and if it's warm to touch, what kind of a vascular malformation would this be? An arteriovenous vascular malformation. And you have to be specific. So if that question comes on your quiz or an exam, I want you to be specific that this is an arteriovenous vascular malformation, because those are two big clues that helps you to make that diagnosis. Okay. So how do we treat these, right? So this is a bit tricky because a lot of times if it's a really small lesion, you don't have to do anything about it. You just observe, okay? If you're dealing with a hemangioma, so for example, if you have a child that comes to your office and you see this vascular lesion and you're suspecting that this is a hemangioma, then you just want to observe it, okay, if it's a single lesion. You wait until the kid turns, about 9 years of age and see if it regresses on its own. If it doesn't go away, and if it continues to grow and if it's interfering with function, then you send them to an oral surgeon so it can be removed. Okay, because the problem with these vascular lesions is they have the ability to bleed profusely. So sometimes it actually causes more problems than actually benefit by taking them out. So if it's not functionally impairing, if it's not aesthetically impairing, you're better off just watching. Okay, or if it's not impinging on any vital structures, you just leave it alone and don't do anything about it. Okay. So there's another type that's called lymphatic malformation. So whenever we talk about malformations, you're looking at both blood vessels as well as lymphatics, right? Lymph channels. So if this malformation is affecting the lymphatic channels, then you use the term lymphatic malformation to describe that. It's a benign lesion. It's a tumor-like growth. Some people think that this is actually not a true tumor and just like a hematoma, but there's other theories that say that this is a true tumor. But for your purposes, think of it as a true tumor. Okay. So what do we see in a lymphatic malformation? In the oral cavity, what do you guys see here? Where is the abnormality? It's on the dorsal tongue, right or left tongue?
Right.
Patient's left.
Yes.
Right? Patient's left tongue. Okay. What is the abnormality? What do you guys see here in this picture? What is the difference between right and left here?
Relations. Redness.
Does it look like a single lesion or multiple lesions?
Multiple.
Multiple. Do they look like they're clustered together? Okay. So this is the description that I want you to keep in mind for lymphatic malformations. They're usually seen as these multiple structures that are clustered together. What do they look like? Do they look like they're filled with a fluid? Right? So they look like they have something in them, like a blister, right? So these are blister type lesions. So when we talk about blister type lesions, we talked about subtypes, right? Vesicles, bulla, and pustules are blister type of lesions. So these would be considered a vesicle because they're smaller than 5 millimeters in size. Okay, so you have multiple vesicles that are less than 5 millimeters in size that are clustered together. Okay, what does this remind you of? You have to think of a food item.
Tapioca pudding.
Tapioca pudding, right? So that's basically, I mean, pathologists love to compare everything to food. So this one looks basically like tapioca pudding, okay? Or they also think it looks like frog's eggs, okay? So basically it's a cluster of these really translucent vesicles, you know, that you see on the tongue, and what it does to the tongue is basically causes enlargement of the tongue on the side that it's affected. So it causes macroglossia, okay? So, but this is your typical presentation with lymphatic malformation or a lymphangioma, is you have this clusters of translucent vesicles, multiples of them, together on the dorsal tongue. Okay, and it usually affects the anterior half of the tongue more than posterior. So again, depending on where you see it, what is the location, you know, the treatment depends, right? If you see something like that that's affecting half of the tongue, it might be really difficult to surgically remove it, okay? So they may try other therapies like cryotherapy. So maybe they may want to freeze the tissue, you know, in that area. They may laser it, okay? So it just depends on how extensive it is, you know. They may be, or they can inject a sclerosing solution into these vesicles that causes it to heal, okay? So there's different therapies that can be utilized, again, depending on the size of the lesion and where exactly is it located, similar to vascular malformations. Okay, so this one I'm just going to briefly touch upon it, okay? The likelihood of you seeing this in your clinical practice is not very likely, but the one patient population group that you might end up seeing Kaposi's sarcoma is the patients who are HIV positive with AIDS, okay? So that's the big risk group. Patients who are HIV positive and who have AIDS, more likely, if it's not controlled and if they're not on medications, the antiretroviral therapy, there is a likely possibility that they can end up developing this malignancy. This is a malignant tumor. It's a sarcoma, right? So it actually affects the connective tissue component. So before AIDS came along, this was not very common, Kaposi's sarcoma. It was basically localized to certain population groups, okay? But unfortunately, with the advent of AIDS, there was an increase in the number of cases of Kaposi's sarcoma. But the good thing was, once they started using the antiretroviral therapy, the incidence of this disease has drastically dropped down. Okay, so, and you need to know the virus that's responsible for it. It's called Kaposi's sarcoma virus or human herpes virus 8. This is a subtype of herpes virus. Okay, so do you guys know the different herpes viruses? Dr. Thompson would have touched upon them, right?
Yes.
So there's HSV1, HSV2. Those are the ones responsible for oral herpes and genital herpes. So in that big group of herpes viruses, Kaposi's sarcoma is a subtype of that herpes virus. Okay, it's actually HHV8. So it's the 8th type of herpes virus. Okay. The other type of herpes viruses would be like EBV, CMV. They're considered different types of herpes viruses and they cause different diseases. So what do you see in a Kaposi's sarcoma typically is the patient on the skin will have these multiple plaque-like structures that you would see. And they are vascular, and you know that because of the coloration that's associated with them. So they tend to have this bluish purple color to them, and there's multiples of these. And you're going to see something very similar in the patient's mouth too. Okay, so you get these erythematous lesions on the inside of the patient's mouth, and hard palate is actually the most commonly affected site. Okay, so we just saw a case about a month ago, and this was a patient, unfortunately has a history of HIV and with AIDS, but then they went off their retroviral therapy, antiretroviral, because he's in the prison system. Okay, so he stopped taking his antiretrovirals and ended up getting, what looks like this, a Kaposi's sarcoma on the palate. But hard palate is the most common site. That's the one site in the oral cavity that you have to look in a patient's mouth if they have AIDS to see if there's a chance of Kaposi's in the mouth. You can see a certain type of Kaposi's sarcoma just in patients from Africa. Okay, there is also Kaposi's sarcoma that could be associated with patients who got transplants done, especially renal transplants, kidney transplants. So it can be associated with AIDS. It can be associated with a patient population group from Africa, especially children are affected in that subtype, or it could be patients with transplant associated. Okay. Or you can have the classic type of Kaposi's sarcoma that is more common in the Jewish population. Okay. So the case that I saw a month ago, basically patient had this presentation pretty much, but then it was bilateral. So it was on both sides of the hard palate. So this case that you're seeing here, only the left hard palate is affected, right? So you have this diffuse bluish purple appearance, right? And then you know that this is a mass because there's elevation right here. This is not a flat lesion. So this is not erythroplakia, okay? So this is actually a mass that's bluish purple in color, and sometimes it can cross the midline and affect the opposite side also. Or you can get case like this, okay? Where it's really exuberant, okay? This is not something you're likely to see in your clinical practice, but more commonly you're going to see this if you're dealing with patients, with an HIV positive patient population. This is more likely to be seen. So again, depending on the subtype and the stage of the disease, the treatment kind of differs. So if it's on the skin, they end up doing radiation therapy. If it's an oral lesion, you have to be a little bit more careful with radiation therapy because there's a lot of side effects associated with that. It can increase the risk of developing another malignancy because of radiation. Patients can have dry mouth. It can affect the salivary glands in the area and can destroy the salivary glands if it's in the site of radiation. So there's, and then it can have mucositis. So there's other changes that can be seen. Okay, so then let's move on to some of the common soft tissue cysts. Okay, so a nasolabial cyst. Okay, so when we talk about the next 3 or 4 cysts, it's basically they all arise only in the soft tissue. You do not see them in the bone. Okay, so that's why these are called soft tissue cysts, and they present as a soft tissue mass. Okay, so if you take an X-ray, you're not going to see any bony involvement. So the first one, it's called nasolabial cyst. This is not a very common cyst. It's developmental. So the reason why they think they see this is because either when you look at different processes that can help in the formation of a face, right? You have what's called a maxillary process, a medial nasal process that forms the philtrum and the top of the nose, and then the lateral nasal process, that's the sides of your nose. Okay? So if you have a cyst that arises from the epithelium that gets trapped in any of these lines, it can give rise to a nasolabial cyst. Or it can arise from a nasolacrimal duct. What do we see here? In these patients, you actually see a mass in the vestibule area. Okay? So on the side of the face, where you see the mass in the vestibule, it actually pushes up the ala of the nose. So if you look at the nose of the patient on that side, it looks like the nose is pushed up on that side. Okay? So that's why it's nasolabial cyst. It affects the area of the lip near the vestibule, and it affects the nose on the affected side. Okay? So, and it's a soft tissue cyst. If you take a biopsy, you're going to see just as a cystic lesion. All right? Definitely these masses have to be biopsied. By just looking at it, you cannot tell if this is a neural lesion, if it's a fat lesion, if it's a cystic lesion, because they all look very similar to each other. Yes?
The infections that like get on the right at the apex of the tooth that destroy like
the bone?
Yeah. What are they called?
Those are inflammatory cysts. You call them
but those are
periapical.
cysts. Those
Yeah,
are cysts
they are.
too,
They're
okay.
called periapical cysts or radicular cysts. It's actually associated with the tooth root.
Okay.
Because there's inflammation in the tooth root in the pulp that actually leads to that cystic lesion. This one has got nothing to do with tooth. Okay, this is basically during growth and development of the head and neck, right? If there's some cells that get misplaced and then they get trapped in that area of development, that can eventually give rise to a cyst in the area. That's why they call developmental, right?
Okay.
So this is not got nothing to do with inflammation, with teeth, nothing at all.
Okay, cool. Thank you.
Okay, no problem. And like any other cyst, this has to be completely taken out. That's the only treatment for it, okay? And once you take it out, they don't come back. There's another type of cyst that you see it just in the floor of the mouth. So all of these cysts, right, they have specific locations in the mouth. So it's important to remember what's the most common site. Nasolabial cyst will be in the vestibule area, on the upper lip, right? And it affects the nose and the lip area on the side, where you see the mass. Dermoid cyst is only seen in the floor of the mouth, okay? And it's usually seen in the midline. So dermoid cyst is also a developmental cyst. Again, this arises during growth and development where something goes wrong and gives rise to the cystic malformation. So this is what you would see, okay? So usually you see it in the midline, okay? And you see it in the floor of the mouth. And then sometimes what happens is, so there's a muscle in the floor of the mouth that's called geniohyoid muscle, okay? So depending on where this mass is, if it's above the geniohyoid muscle, what it does is actually pushes the tongue up and back. So the patient, what will happen if the tongue goes up and back? Difficulty in? Difficulty in swallowing, difficulty in speaking, difficulty in eating, right? And they can sometimes die, if it goes back because it can block the airway, okay? If it's below the geniohyoid muscle, it gets pushed into below the chin, right? So it looks like the patient has a mass underneath the chin. So if it's above the geniohyoid, it pushes the tongue up. If it's below the geniohyoid, it looks like a mass underneath the chin, okay, like a double chin kind of appearance. But they're always in the midline, dermoid cysts. Remember, if you see a mass in the floor of the mouth and it's right in the midline, and if the patient had it for a while, the likely possibility is this is a dermoid cyst. Okay. And this is the double chin appearance. So if it's below the geniohyoid muscle, it can look like a mass underneath. Okay. That's very subtle. Dermoid cysts, again, the treatment is surgical removal and they don't usually come back. Okay. There is a type of cyst that you can see in the mouth that's called oral lymphoepithelial cyst. And this is usually seen wherever you see accessory lymphoid tissue, like extra lymphoid tissue in the mouth. Okay? So, and they think it either arises from this oral lymphoid tissue or from the ducts of the salivary glands in the area. Okay? So how do we see it? We basically see it as a yellow mass. Remember I said when we look at yellow lesions on the side of the tongue, you have to think of few things in your differential diagnosis. One was, neurofibroma. We talked about granular cell tumor. This was another entity that you should include, oral lymphoepithelial cyst. And this has a yellowish hue, and this is seen wherever you tend to see extra lymphoid tissue in the mouth. So it can be seen in the floor of the mouth. It can be seen on the lateral tongue, like this. Okay, so what normal structure do you see here? The posterolateral tongue? What papillae?
No.
Foliate papillae, right? Apart from foliate papillae, what other structure is there in that area? So below the foliate papillae, there's some normal tissue. Lingual tonsils. So you get this lymphoid tissue right below the foliate papillae, right? So this arises from the lingual tonsil because that has lymphoid tissue in it. Okay? So this oral lymphoepithelial cyst can arise from that, and that's why that's the most common location. So any place in the mouth where there's this accessory lymphoid tissue, you can have an oral lymphoepithelial cyst arise from that, and they usually have a yellow color to them. So you can have it in the floor of the mouth, in the lateral tongue posteriorly, in the tonsillar area because you see accessory tissue in that area too. And the treatment is surgical excision. So let's stop right here. We've got two more entities. I'm going to decide if we're going to cover that or not, right? So I'm going to speak with Dr. Richards and see if that's something I want to include in the topics that we're going to cover for you. If not, we'll move on to our next topic. I'm going to lecture for you guys on Monday next. Dr. Richards is going to come back, and she's going to lecture for you on Wednesday and Friday. And it's going to be on epithelial lesions. Okay? Do you guys have any questions so far?
Thank you, Dr. Brown.
You're welcome.
No, about this.
Oh.
They're the same.
Oh. Same model, huh?
Like,